everyone. I'm a fellowship-trained sports medicine surgeon. I did a sports medicine fellowship at Stanford University with a dedicated focus on injuries to the shoulder, elbow, hip, and knee. I see patients at the Sawmill and Perimeter office locations in Upper Arlington and Dublin. Today, we're going to focus primarily on medial and lateral epicondylitis. These are commonly referred to as golfer's elbow and tennis elbow, although the vast majority of people sustain these injuries while not playing a sport. The medial epicondyle is the bony prominence on the inside part of the elbow, while the lateral epicondyle is located on the outside part of the elbow. These serve as the origin for the tendons that control motion of the hand and wrist. The tendons from the medial epicondyle help to flex the fingers, hand, and wrist, as well as rotate the palm downwards. The lateral epicondyle tendons do the opposite and control hand, wrist, and finger extension and rotating the palm upwards. The primary cause of injury is repetitive overuse or stress on the tendons, with the incidence peaking in patients aged 30 to 60 years old. This overuse injury can occur in recreational or competitive athletes, manual laborers, and office workers engaged in performing the same upper extremity motion repeatedly over an extended period of time. This can be swinging a hammer, typing on a keyboard, or even shoveling the driveway. This can result in tendon degeneration or even tearing. Patients typically present with elbow pain that is worse with wrist and forearm motion. They can also have pain and weakness with gripping, making it difficult to perform normal daily activities or play sports. In patients with tennis elbow, the symptoms are mainly located on the outside part of the elbow, while patients with golfer's elbow have pain on the inside part of the elbow. Patients with medial epicondylitis or golfer's elbow can also complain of numbness that radiates into their small and ring fingers on their hand due to the high incidence of ulnar nerve irritation in these patients. Elbow radiographs are often the first-line imaging of choice. X-rays can help to identify fractures or arthritis that may be causing pain. They can also show calcification of the tendons in patients with long-standing symptoms. In cases in which there's a high suspicion of tendon tearing, or patients have failed to improve despite several months of conservative treatment, then MRI or ultrasound may be indicated to assess for medial or lateral epicondyle tendon degeneration or tearing. In cases of mild tendon degeneration or small partial tears of the medial or lateral epicondyle tendons, non-operative treatment is the mainstay of care. This includes a combination of rest, activity modification, braces, home exercise program, physical therapy, and medications. Medications can include oral anti-inflammatories or steroid injections, and newer treatments such as platelet-rich plasma injections have also shown some promising results. This conservative treatment has been shown to be effective in relieving symptoms and allowing patients to return to their sports or whatever activities they enjoy doing in 80 to 90% of patients. Surgical treatment is reserved for patients with moderate to severe tendon degeneration or tendon tears causing them significant pain and dysfunction. Surgery is done as an outpatient procedure. The goal of surgery is to remove the diseased portion of the tendon and reattach the tendon to its anatomic location on the medial or lateral epicondyle. This is done with sutures and anchors attached to bone. In patients that have numbness in their hand related to ulnar nerve irritation, in addition to their medial epicondylitis or golfer's elbow, then the ulnar nerve is also addressed to alleviate those symptoms. Physical therapy typically starts 2 weeks after surgery. Patients are placed in a brace postoperatively for 6 weeks. Strengthening is then initiated. They can usually start a return to sport training around 3 months, with full return to all activities, including high level of sport, by 4 months after surgery. Outcomes after surgery are excellent, with most patients reporting significant improvements in their pain and function after surgery.